Okay, I hope you can see my presentation clearly. If you have any questions, you can stop me during, or maybe you can ask questions during my presentation, or you can stop me. No, I give you sometimes after the about maybe 15 to 10 minutes after the presentation to ask questions. Okay, but if anything during the presentation, if you have any questions or something that you don't understand and you want to clarify and you want me to explain more, please stop me and I'll try to explain. Okay. Okay, let's start with the ACL injury. Okay, so ACL injury is quite common in adolescent and also adults, again, especially the young adults who is active in sports, especially in football, futsal. Okay. So it's a bit of introduction. ACL is an intracapsular ligament. Okay, we have two main intracapsular ligament, which is ACL and also PCL. But they are both extrasynovial, meaning that the location of the ligament is inside a joint, but actually there is a covering ataupun dia ada macam apa synovium yang cover the ligament inside the joint. That's why we call it extrasynovial. Okay, the main function before we go further, we must understand the function. So the function of ACL is to prevent over-translation of the tibia over femur. Okay, that is number one. Number two, together with the first function, it provides rotational stability. These are two main functions of the ACL. So not only the translational stability, but also provide rotational stability. Okay. This actually explains why a patient who sustain injury ataupun without the ACL, in an ACL deficient knee, okay, they cannot perform certain maneuvers ataupun pivoting punya movement. Okay. And then resist varus and also valgus force actually, and the function is it provides a proprioceptive function to the knee. Okay, proprioceptive ni macam mana dia tahulah lutut tu kat mana kan, lutut kiri kita macam kalau you tutup mata macam ni tahu lutut kiri, lutut kanan kan. So that is one of the function of the ACL, proprioception. So mechanism of injury of the ACL, I think about 60 to 70% is a non-contact type. Okay, non-contact pivoting injury. Okay, so maksud non-contact ni maknanya dia tak ada contact directly to the knee, tapi the force comes distal to the ataupun distal ke proximal ke from the knee. Okay, pivoting ni maksudnya dia in other words is macam twisting lah, twisting. And then others is direct and also indirect contact. Okay, dia ada sometimes dia describe as hyperextended knee kan. Dia ada juga kita cakap macam awkward landing patients after awkward landing kan, dia let's say dia main bola, dia nak tanduk bola and then dia landed with the hyperextended knee ataupun awkward landing of the involved knee kan, dia akan cause a ACL rupture ataupun ACL tear. And then other than that, multi ligaments lah. Kalau you ada trauma ke kan, a very violent energy that being transmitted to the knee joint can cause also ACL injury. So mechanism is an important aspect in a history taking lah. You need to ask and clarify with patients what's the mechanism injury during the event lah. So in the history is very important. Okay, if you this one je, I share lagi satu. Okay. This is an example of a hyperextended punya mechanism lah. Kalau you tengok selatan dia dia daripada lompat tu, and then dia landed on the right knee kan, not with proper punya ni kan, dia landed, the knee become hyperextended, and the injury is ACL lah. Okay, tengok slowly. Okay, it's a hyperextended punya mechanism. So one of the mechanism, and another one is pun sama jugalah kalau you tengok yang ni. Okay, dia awkwardly landed on the right knee. Okay. Sometimes the mechanism is shared with other structure injury line. For example, you bayangkan kalau the knee is hyperextended, it will cause actually the capsule, the posterior capsule to be stretched. Okay, so sometimes the posterior capsule also may be injured lah. Okay, associated injury macam saya cakap tadi kan, so dia for the knee to be for only one ligament to be injured is very rare. Okay, sebab kalau theoretically kalau kita fikirkan, kalau knee tu dia nak inject satu ligament, mestilah ligament lain tu pun akan di-injectkan sekali kan, sebab they work together to provide stability to the joints. Okay, so dia sama ada dia yang structure lain tu dia just mildly ataupun mildly involved ataupun just ataupun teruk je lah, sama ada dia koyak sikit ataupun koyak teruk je. Sometimes it can be treated conservatively lah for other structures. Sometimes they may need to be repaired ataupun reconstruct together with the ACL. So in acute injury, okay, commonly injured associated injury is a lateral meniscus tear. Okay, so you dapat patient datang kat ED kan, with a swollen knee, so kebiasaannya akan ada kalau ada lah injury, associated injury, the lateral meniscus is commonly get injured as compared to the medial meniscus. Okay, let's say lah patient ni dia tak ada dia datang kat you after 6 months, after 1 year, okay, with a instability. So in this type of patient, okay, dia in a chronic ACL deficient ni, so the things that you need to rule out is the example of medial meniscus injury lah. Tak semestinya medial meniscus lah, tapi yang ni ialah common patient who neglect the injury kan, dia biar je, and then dia main je belasah pakai dia punya ni tu, so dia commonly get associated medial meniscus injury. Other than that, chondral lah, chondral injury, you punya cartilage, and also in the long run you will get arthritis. Okay, so in acute setting lateral meniscus, in a chronic setting medial meniscus. Sometimes dia boleh keluar dalam you punya BAQ atau MCQ lah. Okay. So kalau you tengok epidemiology kan, actually it's quite common in a female patient lah, female athlete. This is due to the several factors. One of it is in terms of activations of group of muscle, sama ada you punya quadriceps ataupun hamstrings. Maksudnya kalau in a certain position tu, perempuan ni dia punya quadriceps tu lagi dominant. Apa maksud dominant ni? Maksudnya dia will get activated stronger than you punya hamstring. You punya counter punya muscle is hamstring kan. So quadriceps kalau you tahu dia function is to extend the knee kan. At the same time dia actually bring forward your tibia anteriorly. Okay, so this quadriceps dominant ni maknanya dia tend to bring your tibias anteriorly forcefully lah kalau dalam keadaan injury itu. So the ACL will get stress lah, dia akan stress, so dia ada higher chance to be injured. Other than that, perempuan dia punya intercondylar notch yang tengah tu kan, kalau you tengok nanti dia tunjuk gambar, dia smaller, the intercondylar notch is smaller, so ruang untuk ACL tu quite small lah. So due to the smaller notch tu, dia get senang dapat ACL injury. And then the size of the ACL itself, okay, is smaller as compared to men, and also the laxity. Okay, perempuan ni dia sebab dia ada banyak hormon kan, so hormon dia ni dia affect the laxity of ligament, so they are more flexible, they are more lax. So
Doktor, sorry.
yeah.
Doktor dalam next slide ke? Macam tak gerak je.
Okay, sorry, I tak tukar yang slide.
Okay.
Okay dah nampak?
Nampak dah.
Okay. So nilai why more common in female actually. Okay. So these are the causes, ataupun the explanation lah behind the kenapa perempuan lagi common daripada lelaki. And then functions kan macam saya cakap tadi, prevent anterior tibial translation, restrain tibial rotation. Dua-dua ni penting untuk you faham untuk we are as surgeon, we want to restore back the both yang atas dua ni lah mainly. Okay, the anterior tibial translation, also the tibial rotation, so that patient can involve in future in a pivoting punya sporting activities. And then bundles. Okay, ACL as you know consists of two bundles kan. Based on the tibial attachment. Maksudnya dia punya nama tu based on the location of the tibial attachment. So dia ada AM bundle dengan PL bundle. The AM bundle is anteromedial, PL is posterolateral. Okay, AM bundle, I think this one you don't have to memorize, tapi it's good to know actually. It's isometric. Isometric ni maksudnya throughout the knee range of motion, dia punya panjang tu sama aja for the AM bundle. Maknanya the length is, you know right, our ligament is viscoelastic material. Maknanya bila elastik ni, kalau sepatutnya dia boleh stretch lah kan, maknanya dia boleh memanjang, boleh memendek. Okay, but the AM bundle is isometric. And it actually tight throughout the range of motion. Motion maknanya 0 440, dia memang sentiasa tegang je. Okay. Tapi paling tegang masa in a flex position. And then actually the specific test for the AM bundle ni actually, if you perform anterior drawer test and also Lehman test. Okay, this is to test the AM bundle. And then for the PM bundle, dia panjang. Okay. The tight and tightest in the extension. In a mid flexion ni masuk dalam 30 ke 60 kan, 60 degree. Macam tu dia slack tu maknanya dia tak tight. Okay. Dia kalau you assess arthroscopically, you rasa dia macam lembik je lah. And then the test for the PM bundle actually pivot shift. Okay. So kalau you tahu the maneuver for pivot shift tu, kita ada involve rotation kan, internal rotate and then flex the knee. So actually we are assessing the PM bundle which provides the rotational stability. So macam saya cakap tadi, the first function is to prevent anterior over translation. Keduanya rotational stability. So AM provide prevent over translational of tibia over femur, and so the PM bundle provide the rotational stability lah in a biomechanics study. Okay, ni gambar sikit lah. So you tengok medial meniscus, lateral meniscus, you punya ACL. Actually the footprint, kalau you tengok ni kat antero medial kan, maknanya yang you nampak ni ialah dia punya AM bundle lah. Okay. Posterolateral maknanya dia dekat belakang AM bundle ni, and then slightly lateral. Okay, kalau you boleh nampak arrow eye ni kan. Okay, that is a PL bundle. Kalau you baca banyak lagi kan, you boleh, sometimes they describe it, our ACL ni macam a ribbon-like structure lah. Not a distinct, ada distinct bundles lah, different bundle. Sebab bila you flex, dia akan jadi ribbon lah, dia macam pusing on the axis of the fibers. Okay, this is on the sagittal cut. You tengok, this is the lateral femoral condyle. LFC is the lateral femoral condyle. Macam mana dia attach kat situ. The footprints of the ligaments ni sangat penting untuk surgeon lah, untuk kita reconstruct back as anatomical as possible lah. Okay. Dalam kes ni boleh nampak dia punya, this is your medial meniscus kan, ni medial meniscus, MTC medial tibial condyle, okay. Lateral tibial condyle, tapi lateral meniscus tak ada, okay. Dia dah reset keluar kot. Okay, another pictures kan, you boleh nampak AM bundle, inflection, dia posterolateral bundle dia slack, okay. Dia tak tight. Okay, in extension of the knee, yang bundle dia cakap tight throughout the range of motion kan, tapi ni dia cakap slightly slack, tapi nampak macam tegang gitu kan. Then the posterolateral bundle is taut ataupun tight in the extended position of the knee. Okay, footprints, I think I have ni kan dah cakap tadi, I think this one you no need to ni lah it's more towards technical bila you nak buat surgery. Okay. Okay, another example the pictures showing the footprints of the ni lah. Kalau macam ni, this is your AM bundle, yang belakang ni ialah posterolateral bundle. Okay, ni sama lah. Kalau femur dia lain tau maknanya kalau you tengok sini AM bundle kat anterior kan, yang ni dia dekat sini dia macam lebih posterior untuk AM bundle tu. Sebab tu yang I mention the AM and PL bundle ni actually is named according to the tibial attachment of the ACL. Okay, this is arthroscopic view. Ini in a flex position. You can see A is the upper border. Okay, kalau you tengok, this is the upper border lah. Kalau you tengok I punya cursor ni, the upper border of the ACL attachment. And B is actually bifurcate ridge lah, dividing the yang antara hitam dan putih. Okay, that is a bifurcate ridge. So biasa kalau kita nak reconstruct the knee ni, kita aim for the center lah, center of the footprint at the femur. Tibia senang, tibia masih tak ada masalah. Femur ni selalu orang buat silap lah, intraoperatively. Okay, tibia ni tak apa. Okay, blood supply and innervation, middle geniculate artery. Okay, it comes from the middle geniculate artery, and also for the innervation from the posterior articular nerve branch of a tibial nerve. The strength of ACL is 2100. Okay, so bila kita nak reconstruct kan, technically we must have a similar ataupun higher graft strength lah, supaya nak ni lah kan, nak dapatkan balik sama strength as a native graft, native ACL. So our graft to replace ataupun to be reconstructed must be stronger. Kalau you tengok, kalau kita ambil quadruple hamstring kan, biasanya kita ambil hamstring kan for the ACL reconstruction, and then kita lipat 4. Quadruple tu maksudnya hamstring tu kita lipat 4 and then kita reconstruct lah, letak kat dalam tu, is about 4,000 Newton, higher than the native ACL. BPTB ni bone patella tendon bone. Okay, we take patella tendon as a graft, and the strength is about 3,000 Newton. Okay, memang dia lebih jauh daripada the native ACL punya strength. Tapi you kena ingat, bila kita buat reconstruction, memanglah initial strength is 4,000, 3,000 kan, tapi it will get weaker lah. Sebab ada necrosis kan, bila ada necrosis, sebab itulah kita kena buat rehab semua kan, sebab dia akan the weakness will be the graft will be weaker lah, not as strong as this one yang dia ukur ni semua awal-awal punya strength lah. Bila ambil tu kan dia buat biomechanics study, dia dapat 4,000, 3,000 macam tu. Okay, come into the important part for you all lah. So history, from history, kebiasaannya kalau dalam exam, of course patient akan datang you chronic patient lah, tak adalah. Chronic ni macam-macam lah definition, more than 6 weeks and more than 1 month. Tapi most likely patient dah lama lah, takkan kita ambil acute untuk hantar exam kan. So kalau in a exam kan, you must ask about the injury lah kan, macam mana dia injured, MVA ke ataupun sporting activities, and then determine the mechanism lah. Okay. Then next question is, you need to ask about sound lah, any audible sound. Okay, biasanya pop sound kan, is very characteristic for the ACL injury. So, and then after that, you need to ask about whether the patient can actually continue with the activity. Kalau dia tengah main bola tu, lepas dia kena tu kan, dia boleh main lagi tak? Okay. So actually that determines, biasanya ACL ni kalau dia partial ataupun just a sprain, dia patient boleh main je lagi. Okay. Tapi kalau dia complete tear ataupun sometimes partial tear pun dia tak boleh main terus lah. Okay. Due to the severe pain and also hematrosis lah. Okay. And then next question is about the swelling. Okay. Whether the swelling delayed ataupun kalau patient cakap hari ni saya injured, esok baru saya perasan bengkak. Okay, maknanya more than 12 hours, most likely it's not ACL lah. So you need to think about meniscus. Kalau dia injured immediately, okay, maknanya dia ni, okay, maybe complete rupture of ACL ataupun boleh jadi osteochondral injury ataupun avulsion injury of ACL ke PCL ke. Okay. So that's a differential lah. The importance of asking how fast the swelling develop. Okay. And then okay. To history lah about the. So actually from the history itself you dah boleh tahu dah sebenarnya dia ada apa kan. So you dah boleh ada dalam kepala otak you dah boleh ada lah differential kan, apa yang you nak letak untuk patient. And then next question you need to ask about instability. Macam mana you nak tanya, you can ask about ada rasa longgar ke tak, ada rasa lutut tu macam jalan long lie macam tu. Okay. And then kalau patient dia nak naik tangga, turun tangga ada masalah ke tak. ACL selalunya turun tangga kan. And then kalau jalan on uneven surface, ada masalah tak? Ada tak rasa lutut tu longgar? Biasanya soalan ada tak lutut tu longgar? And then you can ask for the question, kalau jalan atas permukaan rata, okey ke tak? Atas permukaan tak rata, okey ke tak? Naik tangga, turun tangga, nak bersukan macam dulu, okey ke tak? Okay, maksudnya kalau you nak buat, okay, sometimes ada patient dia punya simptom tu hanya certain activity je. For example, pivoting punya ni lah, you punya pivoting punya activity. For example, you nak main bola, you nak lari, nak turn position, nak turn, you nak stop suddenly and turn you punya direction tu, dia tak boleh buat. Dia boleh dia cakap spesifik, itu yang dia tak boleh buat. Tapi selain tu, jogging, jalan pun tak ada masalah. So you need to ask carefully lah and thoroughly about the instability symptoms. Inilah inability to return to sport. Sometimes dia aktiviti harian lain dia okey, cuma nak main sport balik tu dia tak boleh. And then presence of mechanical block. Ini ada locking ke, tak ada locking ke, okey. So you boleh tanyalah lutut tu ada masalah. Locking ni maksud dia you cannot extend fully the knee usually. So you boleh tanya patient lah whether patient ada masalah untuk nak luruskan lutut tak, ataupun sometimes boleh, sometimes tak boleh. Macam tu. Okay, that is the question that you need to ask during the you punya exam lah. Cepat je kan? I think kalau you tanya soalan ni laju, okay, I think 1 minute you boleh settle lah semua untuk tanya pasal ni. Okay, physical examination. Perform all the knee examination, kan? I think you know how to perform ni. And then specific for the special test for the ACL injury is you punya anterior test, the most sensitive test is ligament test, and also your pivot shift test lah. Pivot shift test ni tak payah buat, anterior test, ligament test, please do during the exam. Okay. Ini boleh termasuk dalam teori juga, mana yang most sensitive, mana yang most specific. Okay, for imaging Sigon fracture, nanti saya tunjuk gambar. Okay. So let's say you dah sampai ke diagnosis kan, say lepas dah discuss semua, then you cakap my diagnosis is ACL injury. Okay. Then what you want to do next? I would like to request for a plain radiograph, AP and lateral of right knee or left knee. Okay. And then I would like to look for any sign of ACL injury, such as indirect sign kan, pathognomonic Sigon fracture. Okay. What is Sigon fracture? Nanti saya tunjuk. Then for MRI, you can request the indications ataupun why you want to perform MRI. You want to look for associated injuries. Okay, that's the skema jawapan lah untuk you jawab bila you exam nanti. Kenapa, kalau dia tanya kenapa you nak buat MRI, I would like to look for associated injuries such as tadi lah, meniscal, condyle injury, okay, ada ligaments involvement, PCL, PLC, you punya MCL, LCL, okay. So in MRI, tak apa, you tengok dia punya ni baru you boleh faham. Okay, this is an example of apa dia panggil, second fracture. Okay, second avulsion fracture. This is actually attachment of your anterolateral capsule together with your ALL, anterolateral ligament. Okay, sebab you tahu dia punya mekanisme ni biasanya ada some rotational punya mechanism kan. Okay, so dia actually they avulse together with the anterolateral part of capsule lah. Tapi tak semestinya ada lah. Percentage yang ada I tak berapa sure lah. Tapi jarang lah tengok ada second fracture ni. Di satu kalau with time sometimes dia dah resolve lah, bone tu dah hilang lah. So in a chronic cases jarang you akan nampak lah. And then okay, this is the structure lah to ALL ni ialah anterolateral ligament, dekat mana you punya apa berlakunya you punya avulsion fracture of the tu. Okay, another picture showing the area of the ALL. Okay, this is all the extra-articular ligaments lah, accessory ligament. Okay, this is MRI. Okay, kalau you tengok, this is your ni sagittal cut, sagittal cut of MRI center. Okay, tengah-tengah ni you punya yang hitam tu ialah fiber yang ada putih-putih sikit ni kan, you punya ada hyper intense signal kan, ada increase in intensity of signal in the ACL fibers. Boleh cakap some strain. Okay. Okay, this is injured ACL lah, okay, partial. Okay. Okay, empty notch. Okay, empty notch sign. Empty notch ni kalau hitam tu actually not an empty notch lah, maknanya dia normal lah. Hitam kan kalau you punya fiber of ligament ni dia hitam tau. So kalau dia kosong macam ni maknanya ada injury lah, apa ACL tu tak ada ataupun dia injured lah. Another sign is ataupun yang benda findings yang you boleh tengok ialah bone bruising. Okay, yang putih-putih ni kan dalam ni kan kat sini. So one thing that you need to understand, the bone bruising actually is not at the site of the attachment actually. Bukan you kata dia ada bruising kat sini sebab dia tertarik ke kan ligament tu. Dia actually disebabkan hentakan during the ataupun macam sort of compression lah, macam violently compress this area kan during the injury. Some may even say that actually the hentakan ni actually the cause of the sound pop tu. Okay, it's not due to the ligament rupture, due to this thing. Maknanya cartilage over this area dengan this area dia berlagu masa the injury itulah. That's causing the pop sound. Not due to the ruptured ligament. Okay, so bila dah lepas ni kan, so you boleh cakap lah kan, so this is ACL. Okay, so they will ask you about the treatment lah. Okay, so treatment generally for ACL injury can be divided into acute dengan chronic presentation lah. Tapi dalam case you biasa chronic kan, so you always start with a non-operative. Kan, in a non-operative biasanya physiotherapy. So you want to get a full range of motion and you want to strengthen the quadriceps. Kita tak immobilize the patient with ACL injury. Okay, this is the natural history of the ACL injured knee. Okay, so dia ada rule of third. Maknanya 1/3 daripada orang yang kena yang sustain the ACL injury ni dia akan continue macam normal lah. Maknanya dia mungkin dia partial ke apa, kita tak ambil kira lah. Tapi orang yang ada ACL injury biasanya 1/3 dia akan jadi normal. 1/3 dia akan rasa kadang-kadang dia ada rasa unstable, kadang-kadang dia okay kan. So dia kena biasa dia mungkin dia dulu dia power gila main bola kan, mungkin dia punya performance tu akan lower a bit lah. Okay. So kalau dia tak kisah, okay lah kan, dia main just recreational, dia main suka-suka satu Ahad ke, ataupun main kadang-kadang je kan, main suka-suka kan. So dia tak kisah. So these two group yang atas ni you can treat conservatively lah actually. That's why not all patient with ACL injury we need to treat surgically. Okay, we must give sometimes. Especially in patient who is not professional ataupun dia not active kan, sedentary, dia dah relax, dah malas nak main ke apa. And then another one third dia memang problematic lah, dia memang dia kacau hidup dia kan, dia kata memang kalau jalan biasa pun dia unstable kan, so this patient actually we need to perform surgery lah. Okay, kalau dia tanya ACL boleh repair ke tak, so tak boleh repair jawapan dia. Okay, that's the explanation lah kenapa tak boleh ni repair, sebab dia ada yalah, memang impossible lah kalau ada ACL rupture untuk di repair untuk korang punya jawapan lah in exam. Okay. Tapi kalau you baca lagi ada banyak benda-benda lain lah, tapi saya rasa tak perlu. Operative ACL reconstruction, habis cerita. Okay. Kalau in exam you, let's say lah, you palpate the joint line, I tell a bit about the apa, kalau untuk patient with ACL injury ni, sebab banyak patient yang ada associated injury, okay, especially you meniscus lah. So meniscus tu kita kena repair sekali lah, repair and then we perform the ACL reconstruction. Okay. Sebabnya macam tadi kan you baca the important yang part ni, you chronic ACL injury ni. So maknanya kalau you buat ACL reconstruction without repairing the meniscus, kalau you repair the meniscus without ACL, without reconstructing the ACL, so maknanya dia akan tend to get a meniscus injury lah. Okay, maknanya kalau you repair, dia akan koyak balik lah in future. So maknanya that's why if a patient is diagnosed with ACL, kalau dia ada meniscus, kita akan repair meniscus, lepas tu kita akan reconstruct ACL together. Okay. That's the rule lah. Kadang-kadang ada one of the student tu dia datang dengan lock knee. Okay. So kita suspect dia ada meniscus injury lah. Okay. And then together masa kita buat scope tu nak repair the meniscus, kita nampak dia ada ACL juga. Tapi kita tak ready lagi kan dia punya ACL implant semua tu, then kita just repair the meniscus first. And then later on baru kita perform the ACL reconstruction lah. So nak bagus actually kita repair together lah with kita buat reconstruct, kita repair the meniscus and reconstruct the ACL together. Okay. Okay, so I rasa untuk korang untuk ACL yang ni dah cukup dah. Yang penting history lah. History tu you must kena tanya soalan yang macam yang tanya tadi tu je. Okay, from there you dah you habis history without even clerking, without even examining the patient, you dah boleh tahulah the diagnosis, your provisional diagnosis. And then apa lagi penting? Oh sorry, I missed about the ni lah. One of the findings that you can observe during the apabila patient, when you assess the gait of the patient, is one of the findings is a quadricep avoidance gait. Okay, quadricep avoidance gait ni maknanya dia try to avoid to activate the quadriceps. As you know, the quadricep function is to extend the knee kan. And at the same time bila dia extend the knee tu, actually you punya quadricep tarik tibia anterior kan, macam yang cakap tadi. So dia nak prevent the feel of instability tu, dia try to limit the activation ataupun try to avoid activating ataupun contracting the quadricep muscle. So by doing that, actually dia avoid the feeling of instability of the knee. Okay, so there is a very distinctive gait that you can observe in a patient with a chronic ACL deficient knee. Okay, what we call as a quadricep avoidance gait. Macam mana you nak kena tengok dalam video lah, macam mana rupa quadricep avoidance gait. Kalau you yakin patient tu ada quadricep avoidance gait, then you can mention lah the patient is having a quadricep with a quadricep avoidance gait. And then besides that, kalau dia ada associated ligamentous injury, sometimes dia boleh dapat varus thrust gate, okay? Especially with the PLC and the lateral structure punya injury lah. Okay. Tu untuk ACL lah. Ini question lah for the ACL. ACL ni biasanya soalan apa? Kes yang wajib lah yang ada dalam exam. Ada soalan? Any questions? Tak ada soalan? Faham lah?
Faham, Mister.
Okay. So untuk meniscus meniscus ni I tak ada slide, tapi meniscus ni dia takkan, untuk korang punya clinical dia takkan ada lah macam satu je just memang specific meniscus case, tak adalah. Okay. Biasanya meniscus ni kalau from history tu twisting biasa twisting punya injury kan, dia punya mechanism, and then the swelling will be delayed. Okay. And then patient may come with mechanical symptom ataupun just pain saja. Okay. Mechanical symptom ni maksudnya ada locking, occasional locking, ataupun dia rasa popping, okay. Ataupun dia boleh juga datang dengan instability tapi jarang, okay. Unless it's very severe punya tear lah. And then okay, for ACL tadi dia biasanya ACL alone isolated. Kalau chronic datang kat you, pain is not ni lah biasanya tak ada sakit lah So just the symptom. Dia mungkin terasa tak selesa ataupun ni, tapi sakit tu jarang. Kalau bila patient ada sakit, you need to think about other associated injury lah kalau for ACL. Okay, back to the meniscus. Okay, so pain, mechanical symptom, and also recurrent swelling tu pun you kena tanya. Kalau dah chronic ni kadang-kadang dia boleh ada, dia cakap doktor lepas saya main dia macam ada bengkak. Okay, lepas tu dia surut. Saya stop sekejap dia surut. Lepas tu dia, kalau saya main lagi banyak-banyak dia akan bengkak lagi. Okay, tu pun petanda apa macam most probably patient ada meniscus injury lah. Okay. So examination, joint line tenderness. Okay, joint line tenderness. Mana you need to palpate the joint line properly. Lepas tu McMurray. Okay, McMurray test. X-ray tak nampak apa-apa kebiasaannya, okay. But you need to request for an X-ray, okay. Throughout ada apa? To rule out any other pathology of bone lah. And then MRI lah. The MRI you need to see for the structure of the signal in the meniscus. And also the treatment, okay. For the treatment, kalau macam saya cakap dia takkan dapat meniscus alone lah kalau clinical, okay. Dia mesti ada ACL lah biasanya. Kalau treatment generally for meniscus isolated injury, okay, you always start with physiotherapy je lah 3 months up to 6 months. Okay, unless patient ada mechanical block, ada lock ni, then you kena buat arthroscopic repair lah of the meniscus. Tapi most of the time kalau meniscus alone, we always start with conservative management. Okay, control the pain, control the swelling, get a range of motion, strengthening for at least 3 months. Kalau okay lah maknanya symptomatically dah jadi asymptomatic ataupun dia rasa dah tak sakit dah tak ada recurrent swelling, and okay. Kalau tak okay, then we will need an MRI. Lepas tu kita akan perform repair lah. Okay. That's for the ACL. For the meniscus. Okay, any other question? Any question regarding ACL also meniscus?
Mister, I just nak tanya, if patient tu dah come with, dia datang after ACL reconstruction. Lepas tu macam waktu tu significant lagi ke history yang mechanism of injury apa semua ke?
Let's say kalau dia dah pernah buat ACL reconstruction lah you can ask me je lah about the first surgery, about the first episode of first injury tu. Tapi tak payahlah tanya detail sebab dia dah buat kan. Tapi ada ke kes yang dah pernah buat ni? Pernah dapat masa tanya exam?
Dia datang sebab instability.
Oh, okay.
Lepas reconstruction.
Boleh lah tanya tapi tak perlu in detail sangat lah. Yang penting masa yang bila dia dapat, mungkin dia ada injury lagi sekali ke apa kan. Yang injury yang sekali lagi tu je lah. Kalau ada lah. Sometimes dia tak ada injury pun. Mungkin dia boleh putus balik. Okay. Tapi the first time before the surgery tu macam tak perlu sangat lah kan. Takkanlah orang yang buat surgery tu salah reconstruct kan. Macam buat tak yalah, macam rasanya macam tu macam bawa masa sebab korang ada 20 minit je kan. So tanya about yang kenapa yang apa yang jadi bila yang start dia rasa unstable for the second time ni. Whether it's traumatic ke atraumatic ke. Okay.
Okay, thank you Mr.
Okay, any other question? So let's say lah kalau dia tanya you kalau patient datang dekat ED baru lepas injury kan, so you nak buat apa? So itu senang lah, rest kan. Tu you maknanya you rest the knee kan, ice. Lepas tu you elevate kan. Then you biasanya kita tunggu 2 minggu ke sebulan and then we reassess back lah macam tu. Okay. Always kalau knee injury ni biasa at the first 2 weeks tu kita akan protect rest ice, lepas tu elevate dulu bagi swelling reduce, baru kita reassess balik lah sebab patient tengah sakit kita tak boleh nak assess properly. Okay. That's for the acute part lah. Then after 2 weeks we reassess ACL, then we refer to physiotherapy, strengthening, range of motion, and then tunggulah after 1 month, then kita tanya balik patient macam mana sekarang lutut, okay ke tak, ada rasa tak stable ke. Kalau dia rasa tak stable masa after 6 weeks of the injury tu, kebiasaannya that's the time yang kita decide lah sama ada kita nak teruskan physio ke ataupun kita nak go for ACL reconstruction. Okay. Okay, I think if you don't have any question, I think I'll stop here. Thank you for Thank you for inviting me to give lecture. I hope you all pass with flying colors lah during the exam. I think you all okay good. Biasa most of the IUM punya ni quite okay lah. Okay. All the best for exam. Okay lah. Assalamualaikum.
Salam. Thank you Mr.
Thank you.